Great. And if I could ask my colleagues to continue letting folks in from the waiting room, we will get started. Hi, everyone, and welcome to this month's American Institute of Dental Public Health Innovations in Rural Oral Health Echo session. We are thrilled to have so many people with us today, all of you here, to focus today's call on innovations in rural oral health workforce. And I want to start off by thanking our ECHO partners who've supported us in this effort: CareQuest Institute for Oral Health, UNLV, and the National Rural Health Association, and the Oral Health Progress and Equity Network. I'm Stacy Chazen, and I lead the Leadership and Education programs for AIDPH, and I will be your facilitator today. So quickly going over our agenda, we're going to review some housekeeping items and give you an overview of the call. We're then going to see a didactic presentation from some experts today out in the state of Oregon, combining the physical, behavioral, oral health integration workforce, one clinics model. We'll have some time for Q&A. We're then going to move into the think tank portion of our ECHO call and hear a case discussion on dental therapists as a workforce model in Nevada, go into our think tank breakout groups for some discussion, and then close out. So real quickly, this call is being recorded. The recording link will be posted on AIDPH's website following the call. We ask that you type your email and organization name in the chat so that we can see that you are here. All slides, forms, and materials referenced today will also be available on the AIDPH website. Please be careful about sharing any personal health information during this ECHO session. And if you have any questions about Zoom during the call, please chat with my colleague Liz Flannery through the chat function. And just a reminder, we don't need you to type your name in the chat box because we see that, just your organization and your email address. So we'll save you a little typing there. For those of you not familiar with AIDPH, we are a 501c3 nonprofit with a vision that an equity-oriented oral health workforce prepared to lead. Our mission is to foster professional excellence and advance innovation in the education and practice of dental public health. We do that through a number of activities that cross through our leadership, education, and science and research portfolios. We do national advocacy, and I'll give currently, we're focused on advancing dental benefits for veterans. We recently had a Veterans Oral Health Hill Day in Washington, D.C., which was exciting to do in person. We're leading a number of programs, including the Dental Public Health Leadership Academy, for which applications are currently open for the upcoming cohort. We also have applications open for our annual Summer Research Fellowship and our in-person federal service internship in Washington, D.C. So please visit our website to learn more. For those not familiar with ECHO, the ECHO model is essentially a telementoring model that builds workforce capacity by giving participants both didactic and case-based learning. The idea is that you all participate in these sessions and take the learnings back to your communities. Everyone is encouraged to share, to teach, as well as to learn. And here is a visual representation of what that looks like. So the ECHO model, recognizing that we are in remote areas, most of us are not, or many of us are not in-person settings full-time anymore, and that learning can be done sometimes even more effectively with organizations that are spread across the country and spread across the communities when folks can share best practices and learn together. So this year's ECHO offered by AIDPH is focused on innovations in rural oral health, driven by our recognition of the distinct needs and opportunities for improving access to oral health among those residing in rural areas. Last year, our ECHO series focused on special topics in rural oral health, and we encourage you, if you have not had a chance to, if you didn't have a chance to take part in that, all of the recordings are available on our website. For the current year's offerings, CEUs are available for each session after completing a competency assessment and evaluation, which we will share. And if you complete competency assessments for 8 of 10 sessions that we offer, you will earn a certificate in innovations in rural oral health. And this is basically saying what I just told you. So more details in here, and you can download these slides to have these details captured. Next slide. This month's session, as I mentioned, is focused on workforce. Last month was focused on medical dental integration, and we have a whole host of other rich topics planned out for the remainder of the year. You can learn more about these topics and register for these echo sessions as they get closer by visiting the AIDPH website. Here, we're just reinforcing some norms in terms of respect for folks. And all of these norms are designed to enhance your learning and the experience that you're having here. We ask that everyone use first names to facilitate equality in the discussion. Please add your pronouns to your Zoom name as well. And if you speak, please introduce yourself with your name, your organization, and location so folks know who you are. We ask you to keep your video on, but to keep yourself on mute until you're ready to talk. Limit any distractions, and please respect one another. So the learning objectives for today's call are to examine the physical, oral, behavioral health integration and workforce model combination, identify the logistics involved in physical, oral, behavioral health integrations, and discuss lessons learned from the success stories of Southern Oregon's integration pilot. And here is a disclosure from our presenters. So with that, I am going to turn it over to Kelli Beaumont and Laura McKeane, who are going to introduce themselves and lead us through today's discussion. As they are going along, please feel free to pop any questions you have in the chat box or to save them until the end of the presentation. Kelli and Laura, take it away.
Thanks, Stacy. Do you want us to address questions as they come in, or are we going to wait until afterwards?
Let's see how they come up. If it's something that seems really pertinent at the time, we'll flag those for you. So we'll keep an eye on the chat.
Okay, perfect. And I started my timers to make sure we keep to our 20 minutes.
Oh, you're fantastic. Thank you.
So thanks everyone for having us. We're really excited to be here to share about what we're doing in Southern Oregon. We live in kind of a rural community down here in Southern Oregon, and so we've had to make some creative, innovative changes to see some of our members, and that's what we're going to talk about today. So next slide. I'll just let Kelli introduce herself.
I've been a dental hygienist for over 28 years. I work for Capital Dental. We partnership with Laura here from AllCare, which is a CCO. I work in behavioral health clinics and a pediatric medical clinic. And I have in the past done school-based sealant programs as well.
And next slide. And that's just a little bit about me. I'm just going to briefly describe a CCO here in a little bit. But one of the things that I value a lot about the work that I do is I chair the Healthcare Workforce Committee for the state of Oregon. And we have been really trying to focus on workforce shortages and how we can help those shortages. And so we're making some good strides there. We're not where we want to be, but to have an oral health person chairing that committee is a huge step. So I'm really proud to do that work. And next slide. So this is a little fuzzy, I apologize for that, but this just kind of shows what coordinated care organizations are on the state of Oregon. And if you go to the next slide, Christina. So this kind of describes what a CCO is. So it's a coordinated care organization that's charged with managing the physical health, behavioral health, oral health, and non-emergent medical transportation of our Medicaid members. So there's 15 CCOs in the state of Oregon. And what's unique about that is we have the flexibility in our budget to provide these services how we want to provide them. You know, if we come across something that's not covered by Medicaid, we have the ability to sometimes use flex services to cover those benefits. But we really want to meet the goal of the quadruple aim. I'm sure people have heard that. It's better health, better care, lower costs for the population that we serve, and increasing the care team well-being. And I think that's really important to remember. And next slide. So AllCare Health has been around since 1994. We became a CCO in 2012. Again, we're one of 15. We have, we're now at 60,000 plus Medicaid members in the counties that we serve. We have a couple different lines of business. You can see them there. And these slides are going out so you guys can review them later. And then Capital Dental Care is one of our subcontractors. So we don't directly do dental services. We subcontract with Capital Dental Care to administer the dental benefit for our Medicaid members. And next slide. So why would we want to integrate these particular physical, oral, and behavioral health? We all have heard this before. They're viewed separately from general health. And even though we try and drill this into people's heads that the mouth is a part of the head and the head is a part of the body and the body is a part of your overall health, it just sometimes seems like oral health is at the bottom tier of the spectrum when it comes to health. So we like to make sure it's at the top. And we also think that behavioral health providers, they're in a really unique position to offer interventions to some of these populations. They see these people on a regular basis for counseling, and they're really understanding of the needs of these members. And also because poor oral health, we all know that it can create lots of problems with mental health, substance abuse. I'm sure we've all seen photos of folks that have used meth over the course of their life, and their teeth are just broken down. It's we see this generational aspect of this. Well, my mother had dentures at 25, so I'm going to get dentures at 25, and it just seems to be the norm sometimes, and we want to break that cycle. And next slide. So the model that we decided to go with is we embedded a hygienist, which is Kelli, at a physical health clinic 1 to 2 days a week, and then our behavioral health clinic 1 to 2 days a week. And so in this clinic, we have every type of workforce model. We have a behavioral health specialist, we have a physical health specialist, we have an oral health specialist, and we provide transportation to these appointments for the Medicaid members. So in Oregon, I don't know if everyone's aware, but Oregon has a pretty unique scope of practice for their hygienists. They can perform a lot of procedures without the dentist being on site. And the hygienist salary for this work, it's partially covered by Capital Dental, who Kelli works for, but it's also funded by quality payments from the alternative payment model arrangement that we have with the state. And so we have metrics and incentive measures that we have to meet as an organization. And if we meet those, we get money back, which we turn around and give money to the dental care organizations, who then reinvest it into the community outreach. So that's a wonderful model that we've been using. And next slide. And Kelli's going to talk a little bit about the advantages and disadvantages of this type of model.
The advantages of integration in the behavioral health clinic I work in is the mobile equipment. We can bring it to and from different clinics. We have the flexibility of that, of like, for instance, one of the co-locations behavioral health facilities I work at is called Options for Southern Oregon. And I'm able to take my portable equipment in there and set up in one of their already rooms that they use for the primary care doctor. And I'm able to utilize quite a bit of their equipment and their exam table if it's a lower one. And I'm able to provide dental services through that. We are talking about, I can do quite a bit of things without the dentist being on site. So it allows us hygienists to be able to go into these co-locations and provide services. Whereas if you had a dentist, they are so needed in the clinics now, especially since COVID. It's hard to get them to come to locations like this, and we can do that bridge. We are like the bridge between the behavioral health clinic and the dental clinic. And then next slide, please. The challenges with the information sharing across the oral oral, physical, and behavioral health are sometimes it's the computer systems don't talk to each other as well. So as the last several years, we have worked out ways that we can be able to track patients, and it has evolved over time how we look at things, we reevaluate that, so we can track members that see the primary care doctor and see me as well, and the patients that are in the behavioral health clinics for counseling. And that way we can make sure that they're getting their the next step of oral health care needs being met.
And there's different different coordinated care organizations that contract with different dental subcontractors. So one barrier is, you have to know who your member that you're helping, which dental, they could either have Capital Dental Care or they could have Advantage Dental. And so trying to figure out which one they have is a barrier. And I was just going to say, if anyone ever wants to go into business and work with me to find and invent an EHR that talks to medical and dental and behavioral health, let's do it, because I hope I see that in my lifetime, because I would say that is one of the biggest barriers out there, not being able to talk to each other with these EHRs.
Because some of those places do have, like the primary care has a different system than the mental health. They have two different computer systems, even they're having to go back and forth on those. And then of course dental has their own as well. But the navigation part of it, like if I see somebody that is I work for Capital Dental, if I see someone from another dental care organization, I send Laura here the referral, and she passes it off to that core organization, and then they're able to see them at their clinics. But I'm still able to do whatever services at that time to facilitate that as well, and it gets billed out in a different way. But I can see everybody. I can see people with no insurance too, which is wonderful. So I tell everybody I can see everybody. So it makes me feel proud that my organization allows me to see everybody, not just because you don't have insurance or not, because there's a lot of people on disability that are in that gap that don't have dental care, and I'm still able to navigate them into a clinic that might be lower cost for them as well. Next slide, please.
Care coordination. I like to talk about care coordination because I think it's really important. We want to increase comprehensive dental care for the whole population. So we want to make sure that these folks are getting the care coordination that they need. So options for Southern Oregon will actually keep a separate schedule for the hygienist, and then the practitioners at that clinic will do warm handoffs to Kelli, and then Kelli's able to do warm handoffs to them as well. And so she can make appointments. She sends me referrals. Again, we don't have a system really that talks to each other. So we have to do secure email, not the most ideal way to do business. And I have multiple stickies all over my computer that says send secure, send secure, send secure. So we don't end up not sending secure. And then we get gap lists from Kelli to make sure that these patients are being followed up. And I don't think I put this in the presentation, but our numbers jumped from last year. Our closed loop referral percentage was 22%. So only 22% of the people that we made appointments for followed through to their home dental clinic. And that was 2021. 2022, it jumped to 55%. So I was really, really, really excited to see that it had jumped so high. Next slide. So Kelli's just going to really quick. I know I'm watching my time, Stacy. We're really going to go through quick a couple of pictures of Kelli's setup.
This is just like a basic setup. I have my chair, I have my exam table, I have the compressor that's in the background there that delivers air, water, and I'm able to provide services. And if it's a smaller dental chair, if it's a larger, I do have patients that just sit in a regular chair, and I can do services on them as they're sitting as well. Next slide, please. And this is at the behavioral health clinic. This is just kind of the waiting room, give you an idea. It's a smaller facility. They do have 2 rooms, so I do take one of their rooms when I'm there, but they coordinate their schedule to accommodate that as well. Next slide, please. And this is kind of, sometimes I'm able to just use that chair that they have in there. It does lay back, it does move up and down. I'm able to use their stools, things like that. I do have my computer in the background. I'm able to set up and do basic exams, silver diamine fluoride, sed fills, things like that. I'm able to provide services. Next slide, please. This is just kind of like a little basic setup of your disposable mirror, fluoride gloves. I prepackaged my silver diamine fluoride ahead of time. This helps patients tremendously if they're having lots of sensitivity. We're able to slow down that bacteria, give them some relief. I do have them come back a couple of times to make sure everything on that tooth was covered. Sometimes we have an entire mouth to cover with this, but they come back because they said, oh my gosh, that helped so much. And then when they do see that dental provider, that bacteria is down low. We're going to have more success with having that tooth, a better placement of a filling and things like that. And if not, yes, some of them do need it extracted, but at least we have a lower count of bacteria in there with the silver diamine fluoride help. Next slide, please. And the workflow, it was just talking about like the medical assistant. A lot of times when they're rooming a patient, they'll ask them, when was your last dental appointment? And if it's been more than a year, it's kind of gives them a positive response like, hey, we have a hygienist that comes on site. Would you like to see her? Or if you're having any mouth pain at that time or have experienced pain, then she schedules an appointment with me. They're very proud of like, we gave you a whole bunch of patients today. And when I go into my facilities and stuff. So, and I do track the ones that do see the primary care, but I have a ton that come through my, when they have mental health counseling, they do have a big picture out in the waiting room to direct them to dental services as well. Next slide, please. The scope of services here are the oral health assessments, like I talked about, the fluoride varnish, silver diamine. I do see kids as well. I didn't mention that earlier. I can do sealants with them, nutritional counseling, tobacco counseling, which we partner with AllCare with that. Risk assessment, coordination care is huge. I have so many nervous people, and it is a warm handoff for me also to be able to do referrals, get them kind of prepared to go into the office. I give them paperwork ahead of time. We make their appointments for them, so they have all that in hand. Next slide, please.
So what we're looking at in the future is to have a dentist on site to come into the site 1 day a week, and we'll be able to provide more comprehensive services. A lot of these patients, once they see Kelli, they don't want to go back and see anybody else. They want to come back and see her. And so even though our percentage was really high to the dental home, we do have that population that does have that fear. And, you know, sometimes just getting out of bed during the day is challenging for these folks. So they want to come back and see her. So our goal is to bring the dentist on site to see the patients there. Next slide. And I think we're going to skip this one, Christina, because you guys are going to get the slides. There's a couple I want to highlight. Next one. We'll talk about this one. We'll talk about this one really quick.
This is one where I had a patient come in. He had 17 areas of decay and broken teeth. He was not brushing his teeth. He was concerned, as a lot of patients are nowadays, about what ingredients are in the toothpaste. Well, as he's talking to me, I'm thinking, well, we're going to have you come back. I told him, please come back and see me next week. And I actually went out and got him some natural toothpaste without some of the preservatives in it. I gave him 3 different ones to try. He was able to, the next time I saw him, take this home and start utilizing it. He started looking better. Then I had him come back again because he's in a care facility. he was looking, someone was off that day, and I said, "What's wrong?" And at that moment, he was telling me he was considering not living. He was considering suicide. This is where this integration is really important. And I was able, for a moment, I had to take off my dental hygienist hat and put on my mom hat. And I told him, I'm not, not a therapist, but I want to talk to you. Your life is worth it. And we are going to get you help today. I was able to step outside my room, get him an appointment that day with a counselor to connect him to services. I end up seeing him weeks later, smile on his face, brushing his teeth, doing so much better. These are big wins. These are important that we have all this different type of healthcare providers on site to help these patients along their journey. And you never know when you're going to be an instrumental in any focuses of their life. Next slide, please. And this is the patient I was talking about. And this is a sign that they have out in options to kind of like guide people if they want to make it on their own. And if they don't get a warm handoff, they're able to see me. I also tell patients, they have a lot of challenges in their life. Come back and see me. I've had patients come back and see me in restart services. I do not judge them. I try to be there for them and whatever their dental needs that they have. Next slide, please.
So this story here, it's kind of similar to the last one. This gal was had a terrible living situation. She was getting counseling as well. Again, she felt suicidal. Kelli was able to hook her up right then and there with a behavioral health specialist. And then through the coordinated care organization, we were able to get her assistance and help with her living situation. Next slide. And this is her. And next slide. So this is what we want to do in the future. This is my goal is to have more of this. And when we talked about doing this presentation, I thought, well, this is really more integration than workforce. But then I started rethinking that, and this is having every type of workforce model that I could think of in one clinic, and it's like having the best of everything in one place. And we're making a difference, and that makes the difference to me that we're making a difference in these folks' lives. So dental therapy, we have 9 dental therapists licensed in Oregon now. Pretty soon they're going to be out practicing. I can't wait to see that. And we're going to continue this project. And my goal is by the end of 2023 to have a dentist on site. And next slide. And these are just the websites for our partners that we work with. And next slide. We did it.
Thank you. That was wonderful. And at least on the East Coast here, it's after 3. So this was a wonderful late afternoon pick me up. Really just inspiring what you all have done out there. And when you say at first you thought it was integration, but it's really workforce, all of this stuff, right? It's all interrelated, right? You can't talk about one without the other. And that's what right. It's undertaking this system-wide approach to change. And we appreciate your highlighting this piece of it. So we have a number of questions that came in. We're going to share with you. Pixie Needham posed, do you need a practice agreement or MOU with the dentist in order to practice in medical? And is the dentist responsible for treating the restorative needs of the client?
We did set up a MOU. Yeah, we did with options and stuff.
But you have a collaborative with the dentist,
yes,
so she can practice offsite. Yeah.
Yes, and then yes, for the restorative, they would need to. That's where I do the next step is for the restorative needs. They would need to see the dentist. But the silver dynamine ahead of it helps. We just had a big class on that not too long ago. How that is helping. That's a step that we're going to start implementing and doing in our offices too. So I'm kind of taking care of a couple steps ahead. So I'm preparing those patients for their visit there.
Thank you. Can I just ask a follow-up to that? So the dentist, so that you have the MOU with the dentist, and then is that one of the dentists that you send the clients to for their restorative treatment, or do you have several and you're doing care coordination?
Yeah, so it's offices that have multiple dentists in there. And I work in 2 different counties. So yeah, so I have multiple offices I send them to. And then if it's not like through like Capital Dental, and then Laura takes the handoff from there and sends it off to the other organizations, and and sometimes I tell patients, for some reason, you know, if you hadn't heard from them, they come back and see me. So we make sure that they are getting taken care of.
And
too.
she sees everyone. She sees uninsured as well. She sees everyone regardless of payer. So if it's an uninsured person, we try and get them hooked up with the federally qualified health center in the area to try and get services there, or with the MTI van when they come down, the Medical Teams International.
Oh, perfect. Great. Thank you.
You bet.
Thanks for that follow-up. Meredith Griggs asked, do you do any social determinants of health screeners in the dental clinic?
I don't at this point, but I've seen that where you can do that, but I kind of have to, I don't know, I get to know them and ask them questions and stuff like that.
That's coming. That's
Yeah.
coming, because one of the incentive measures that our organization is going to be held accountable for this year is the social determinants of health and equity screenings. So we are going to look at how we can get that out in different areas, and that will be one location.
And I think, sometimes they need help with their paperwork as well too. So we'll probably try to embed that in with the primary care doctor too.
And that's also where platforms like Unitas come in. Connect Oregon is so that's a community information exchange. And if Kelli comes across someone that needs food assistance, she can use Unitas to plug that person into the system there. I don't know if anyone's familiar with Unitas, but Kelli could go in and input information. It's all secure. And then whoever is accepting referrals for food assistant would pick that person up and get in touch with them, and they would coordinate how to help that person with food assistance. That's just one example. They do housing and all kinds of things, but that's one way to do that we're going to work on.
Excellent. Meredith added, as a patient and healthcare worker, I've even struggled with some of the paperwork. Is there a health literacy coordinator or scripting and training?
A lot of times they have assistance with their counselor, or some of them come to their appointments with them. So yeah, I'm able to connect them with somebody to help them with that. If not, I don't always know ahead, so then I'm like, oh, so I do help them with that. But if we know ahead of time, they do have somebody that helps them. The behavioral health facility is fantastic about helping all their members. Even if they don't have OHP, the Oregon Health Plan, they do connect them with services with that too as well. So sometimes I have to redirect them back to other people, but then we just do another appointment with me.
Thank you, Stephanie, for putting the website in there.
Great. And I just want to offer something. Meredith had asked about SDOH, social determinants of health. And when I was at the National Oral Health Conference last week, I saw a presentation where someone defined SDOH as social drivers of health. I thought that was really interesting, right?
Yeah.
I thought that, and I don't know what the source was, but in my mind, I read that to mean it's not a done deal, right? Even though these factors are going to drive you in a particular direction, they're not necessarily determinative in some cases.
And those patients share a lot of information that, the housing, all that stuff. So you wouldn't think with the dental person, but for some reason they do tell me a lot of information. So we're able to help direct them in those, we came up with other ways, but to have the platform for that's been very helpful.
Okay. I saw one other hand up. We're going to take one final question. Teresa, did you put your hand down? There you go.
I don't have a question, but I will say that a lot of folks that are working in SDOH are moving towards that drivers, so that it's not incumbent upon the individual that is experiencing those things to feel like they are being blamed for them, right? So social drivers of health removes it from the responsibility of the individual to the system itself.
Interesting. Thank you for adding that.
Can I just add one more thing, Stacy, really quick? One of my tasks at the Healthcare Workforce Committee for the state is we have a lot of provider incentive programs, loan repayment programs. People, in order to qualify for that, you have to have a bachelor's degree. And I am trying really hard to change that, because there's hygienists that have associate's degrees. There's nurses that have associate's degrees. To me, that is a barrier of the utmost degree. I can't even tell you how big of a barrier that is. They come out with loan debt just like somebody with a bachelor's degree. Those folks need help. So I'm trying to get that changed. Some people, you know, they don't even want to go into these fields anymore because they won't get help with their loan repayment. So I'm working on changing some of that, because that's a barrier to workforce.
Thank you, Laura. Thank you, Kelli and Laura, again, for an excellent presentation, and congratulations on this great work. And thanks to everyone for bringing your questions. So we're now going to move into the think tank part of today's presentation, and we're going to hear from Melissa Argueta from the UNLV School of Dental Medicine. Melissa, take it away and let us know when we should advance your slides.
All right, thank you. Good afternoon, everyone. And thank you, Kelli and Laura. That was such a great presentation. So again, my name is Melissa. I am the public health endorsed dental hygienist for the UNLV School of Dental Medicine, and I will be presenting today's case presentation. And just to give you guys some background, so Nevada is ranked 47 in the nation for dental services and care. It is critical for all Nevadans to have access to preventative and therapeutic care by licensed oral health care providers. Licensed dental therapists would provide services in public health settings in which 50% of the population meet any of the following criteria: Medicaid enrolled, uninsured, poverty level, or medically compromised. And next slide. And for today's case presentation, Nevada passed legislation to approve a dental therapist workforce model in June of 2019. And to date, sadly, there are no accredited programs to offer training in Nevada and no licensed dental therapist. Next slide. So purpose plan of action is to look at opportunities to recruit dental therapists to Nevada to help address the oral health disparities that exist across the state. And then what we're going to talk about today, ask the group, what strategies can be implemented to go from legislation to practice. Next slide. And for today's case discussion, was that my partner?
No, it is your part.
Okay.
I wonder if you could say a little bit more when you say, how do we go from legislation to practice? What types of things are you looking for from the group?
So when it comes to that, as I mentioned earlier, we don't have any accredited schools. So what is it that we can do when it comes to with our board here in Nevada? Are we going to probably allow maybe coming from another state, going to an accredited school in another state, maybe coming in with a license from that? So that's something, what ideas that we can be looking for to recruit dental hygienists to come and practice in the state of Nevada with this advanced therapy degree. And then
go ahead.
Go ahead.
I didn't mean to interrupt you. Please finish.
And how can we solve the problem? How can we think about it differently? Who or what is missing from the table, and what are the final recommendations?
And we have a clarifying question in the chat. What's the operating definition of medically compromised that you're using?
Anyone that would have special needs, anyone that would have complicated medical history. Is that would be
great. Any other clarifying questions for Melissa in terms of what they're looking for at UNLV in terms of guidance?
So obviously we want to have practicing dental therapists out in the field. We have so many great community projects. I don't know if you guys know, but Nevada is composed of majority rural areas. Las Vegas and Reno are our major cities. Everything else in between is rural. So just how can we bring dental therapists into our state to expand those barriers of access to health? We have a lot of tribal communities as well that could benefit from a dental therapist practicing in our state. So what can we do, obviously, to bring legislation? We need a school. So if we don't have a school, we don't have an accredited school here in our state, what can we do to make that happen and make that happen quick? Because as I mentioned, we passed our model in 2019 and we're already in 2023 and we have no accredited school and we don't have any dental therapists licensed in our state.
Okay, and there's a clarifying question. Is a dental hygiene degree required to become a dental therapist?
Yes, you would need a dental hygiene degree and a master's degree in public health as well.
Wow. That's quite a high bar. Any other clarifying questions before we go out? So Caroline's asking, what barriers have you seen to keeping a program from being developed?
Our board, unfortunately, things are slow, as you guys can imagine, in any other state. Our board we do have a committee that is working on it. But just like everything else, there's priorities when it comes to the dental board. Hygiene is kind of put to the side in a lot of cases, which what has impeded us to actually approve a dental therapist.
Okay. And when you say the board, you mean the state dental board?
The state dental board, yes.
Okay. And a question from Pixie, have you worked with your tribal communities regarding building a dental therapist program?
We don't. We do have public health endorsed dental hygienists just like myself. The only thing is that our access to our work is not as expanded as it would be if we had dental therapists. So we do go out to the rural areas, but we don't have an expanded function where we can provide more treatment to these programs.
Okay. And
Yeah, I'm sorry. I guess my question was, have you worked with the tribes about a program? Because I know in Washington, the tribes actually passed dental therapy for themselves in 2016. And then they, in that period of time, they've uprighted a whole program. And then we just passed it for, legislation was just passed for federally qualified health clinics and rural health clinics. And then a little over $2 million was funded to enhance the program that was already accredited. And so it seems like the tribes, are really invested in doing some of these things. So I was just wondering if that was an approach that you could take.
So I'm going to just ask one more question, share one more question from the chat, and then we're going to go into the breakout rooms to do some brainstorming and move into that part of the discussion. So Kelly asked, can you tell us more about the public health requirement?
The public health requirement for the hygienist?
Yeah, does that refer to, do you mean the Masters of Public Health? She said you need to have a Masters of Public Health. That's what Melissa said. Kelly, can you say a little bit more about what you're asking?
Yeah, can you clarify the requirement for dental therapists to have a master's in public health? So you need to have a dental hygiene license and a master's in public health plus dental therapy training. Is that correct?
Let me confirm that to you. Again, this is all new to our state, so I have that right here. I just read it, but the dental hygienist must be graduated from an accredited dental hygiene therapy program. Obviously accredited by CODA. Receive a master's degree level education and would be similar to a nurse practitioner. So yes, a master's degree level of education, it is not specified whether it has to be a public health.
Thank you.
Okay. So we're going to go into breakout rooms right now and spend about 10 minutes in those rooms doing some brainstorming around the questions here. And then we're going to come back and ask people to share out some highlights. So momentarily, a few people are going to be staying in this main room with me. That'll be your breakout, and other people will be going to rooms. So when you see an invitation pop up in front of you, please accept it. Okay, Liz, are we good? Do you think this is everyone?
I think so. Yeah, I'm gonna go join room 1 now. I just want to make sure we were all set. Annalise, you can feel free to stay or go. You weren't popping up as being able to be assigned. So enjoy.
We'll go wherever you guys want us. If you want us to stay here, we can stay here. You want to throw us in another room, feel free.
No, you can stay here and be a brainstormer, be part of the think tank.
Thank you. We would love it.
So, excuse me. So I know a couple of ideas were already thrown out, and Pixie, you shared that idea about working with tribes on a program, and we're capturing that in the notes. Is there anything you want to say more about that?
Well, I know there are some contacts. One is somebody from Oregon, and I can't think of her name right now, dentist that's been doing dental therapy in the tribes. And then Rachel Hogan, who's a tribal dentist from Washington, who is actually teaching at that program at Skagit Valley up near Bellingham in Washington. And it just seems like maybe following a roadmap of what they were doing, because they were very effective in getting their program set up. Now theirs is going to be a associate's of science program, but I believe that they probably could tweak it some other way to get that dental therapy portion. So, and that's just a thought.
Was it Miranda Davis, Pixie?
Yes, thank you.
Yeah, she's a rock star.
Oh my gosh, she's a rock star. So is Rachel, but yeah, they're awesome.
Rock stars are always good to have.
Mm-hmm.
And they have to train other people to be rock stars before they leave.
I mean, the school so Pacific University has a dental therapy, they have a dental therapy program, but the 9, I guess it's 11 now that we have, they were all trained under the pilot project that we had for the state of Oregon. So they were able to graduate from a non-CODA accredited school. Going forward, since the pilot project bill is going to sunset, anyone that graduates now, the Board of Dentistry says you have to graduate from a CODA accredited school. So now Pacific University in Portland is in the process of trying to become CODA accredited so they can graduate more therapists. Otherwise, they have, if you want to go, you have to go to Swinomish or Skagit, one of those other places.
Yeah, I was just surprised how fast they could get their accreditation, at Skagit.
Yes.
So, yeah, they did a phenomenal job.
Yeah.
And I had another question, if nobody else has a question right now for Laura, is it that, can you guys be supervised in Oregon by a medical provider?
As far as a hygienist?
Mm-hmm.
No, because you have to have a collaborative agreement with a dentist in order to practice independently. So
in order to do like prescriptions and things like that, but
yeah,
the hygienist can go out on her own.
that's true. You're right.
Without the collaborative agreement, you're limited on what you can do, but it can be done. It's just so much easier working with an organization for that. Trying to get into facilities makes it a little tougher without the CCOs and DCOs, I've found. But we still need a lot of work, like in our nursing homes. That's been a huge barrier trying to get into those facilities. I have been able to through Exceptional Needs Dental Service out of Portland, but even with that, it's trying to get the word out. And then, they have like one nurse per facility, and it's I find it challenging to even get in to talk to these people unless you know somebody, which I've been able to do times. But
yeah. So can
I can do on my own. I don't have to have that, collaborative.
So I just want to jump in, and if we have some time at the end, we can come back. But for this session right now, for this breakout, we want to focus on the case from UNLV, and then we can circle back or connect you guys afterward. Do folks have any other thoughts? I'm wondering if anyone else has worked in their state, if they've faced a similar challenge, and or if you're aware of any other states that are doing this well in terms of attracting dental therapists when you don't have a school in the state, and getting them to practice in rural areas.
Would that state license them? I mean, if you graduate from a school, say Skagit, and you went to practice there, would they license them?
I assume they would. Elisa, I see your hand is up. And it's nice to see you here. Oh, you're on mute.
Sorry, I pressed the wrong one. So my name's Elisa. I'm a peer support specialist and pediatrician in Frontier, Alaska. And I'm working with Harvard on the 100 Million Mouth campaign. I'm the Alaska champion. And so I'm in the midst of making connections with our dental therapists program. So Alaska has a robust dental therapist program. It's mainly on the western side of the state, with a lot of the tribal corporations, native corporations. And so I have an introductory email that I've yet to respond to, but so I'm going to be working with them. I think the program's out of University of Alaska, Anchorage. I believe they have a specific dental therapy program where the dental therapists go. I'm not sure if it's online or not, but I will find out more soon.
Thank you for sharing that. Leah.
I'm
Leah.
confused. Do you guys have a dental compact agreement for other states?
Not yet.
Is that something you're currently working on that would help solve this problem? Do you know if there's policy work going on with that?
That's for Nevada, though. Are we talking about, right, Cece?
Yeah, yep, the case is from Nevada.
I just know that's something that we're working on in Kentucky. And it's gonna, I do feel if we get it gone through, that it's going to make things like this easier in the future.
Yeah, that's something we can certainly share as an idea to ask them about that. Yep, and Annalise just popped a resource in the chat. Thanks for that. Did folks think that was unusual that the requirement to practice as a dental therapist called for a master's? Is that something typical in other states?
It is in Minnesota. That's what they do. We don't, and Oregon doesn't require that.
I
Oregon.
think that was intentional to actually stifle the growth of dental therapy in Nevada. I know that was kind of my understanding when I was working with stakeholders there. So I don't know if there's a workaround, but I think that was intentional. It's to actually make it a bit harder. And the fact that there is no program available in the state compounds that. So I think it's a good idea to brainstorm potential workarounds or facilitators, because the structure has been designed intentionally to be difficult around implementation.
Interesting. And Kelly, thanks for sharing that in the chat. The Nevada statute says that they'll grant a temporary license to practice dental therapy. And Wisconsin is looking to pass dental therapy legislation. A master's is not required. Yeah, and I wonder that the temporary, is that based on establishing residency there? Like, I wonder what the temporary, like when that expires, or, you know, if you're at some point able to get a regular old license. That'd be interesting. I think folks are going to be coming back to us.
I've always said, if I tell Miranda and Rachel this all the time, I've been to Alaska twice and seen the program. If I was 30 years younger, I would absolutely have done that. Absolutely.
Ah.
I think it's remarkable.
All right, we're going to give folks just another 30 seconds or so to come flying back through cyberspace. Great. I wonder, does anyone want to share out any ideas that came out in their group? For those who just popped in, just opening up the mic to see if anyone wants to share any ideas that came up in their brainstorming.
I'm happy to do so for my group, Stacy, if that's okay.
Yeah, that'd be great, Caroline. Thank you.
Awesome. So we talked about really just trying to identify barriers or bottlenecks to going from legislation to an actual, accredited program and getting dental therapists in the state. So starting with, well, what are the barriers so we can start to create solutions? And, one of the barriers mentioned was the potentially, the dental board in the state. So offering them some education on the importance of workforce development and around dental hygienists and dental therapists was also a suggestion, really just bringing them to the table, truthfully, more than anything. Yes, we can provide them education on workforce, but bringing the dental board to the table with lots of other different stakeholders to start to solution build around how we go from legislation to actually having dental therapists practicing in the state. That way everyone can buy into what, the solution is for this particular issue is going to be really important. So I think we mentioned, the dental board, academic institutions, providers, payers, potentially tribal communities, all coming together in some sort of maybe convening type situation where stakeholders can really just get familiar with each other, what they're doing, and start to solution build together.
Thank you for that. Great. It sounds like there was a diverse set of ideas across the groups. And we at AIDPH will be pulling together all the ideas into a summary sheet, sharing that back out with all of you, as well as with our case presenter, and putting it on our website in the coming weeks. So stay on the lookout for that. Chris, okay, there you go. So next steps. So CEUs are available for today's session. The survey link, is this accurate? The survey link is going to show up in their browser right after the call. I hope so. Recordings and resources from today's call are going to be available on the AIDPH website. I just mentioned the case summary that we're going to do with strategic recommendations that came out of each of the three groups. If you would like to present a case on a future call, please go to our website and you can find the link there. We would love to have you present. And our next ECHO call will be on May 18th at 3:00 p.m. Eastern. We're going to focus on innovations in community care delivery. My colleague Liz just popped into the chat the survey link that you can grab for getting CEUs, and we'll send that out as well. And maybe it will pop up right after the call. We'll have to see. If not, we'll update this slide for next time. And if anyone has trouble with SurveyMonkey, Pixie, reach out to us directly and we'll see what we can do to help you to still get the credits. So thank you, everyone. Thank you to our presenters, to Laura, to Kelly, and to Melissa for joining us today, and to all of you for putting on your thinking caps and contributing some great ideas to the case study challenge. Have a great Tuesday. Bye, everyone.
Thanks for having us.